So it's my pleasure to introduce my friend Lanny Johnson here. No, yeah, just so in the late 70s, in 1975, I bought an arthroscope, but I didn't really know what to do with it. And then I visited Lanny's exhibit at AOS on a needle scope, and I could see more than I ever saw open, and actually admitted that. So then Lanny was my mentor, and he taught my generation how to do arthroscopy. He opened his OR to any visitor that would come to Lansing, Michigan. And I visited him 4 to 5 times, probably every 3 to 6 months, beginning in 1979, to watch him do knee scopes. And after that, I never opened a knee again. He showed me how to do a shoulder scope in 1980 when I was visiting him. And then his initial books all included shoulder arthroscopy. He was way ahead of the curve. So then Lanny, he's also Dr. Lanny to the Golf PGA Tour. He coaches putting and measures your consistency with an ultrasound device. And so one day he came to see our fellows and out of Shadow Ridge and bought his device. And he told me I was the worst putter he's ever seen. You know, it's true, yeah. So over the years, we've had many discussions on managing our life as a physician. And he told me, you know, if you retire, don't give up your medical license, you know. And so today the topic he chooses is getting better all the time, still a ways to go. So here's Lanny. Thank you for coming. Where's the button for forward? Yeah, you can use this, I think.
My favorite story from my time on the PGA Tour was when Jay Haas came and said, I'd like to have my picture taken with you. Usually you ask the pro to get the picture taken with him. And I said, Jay, what's this about? And he said, well, I went to my orthopedic surgeon a couple weeks ago, and I asked him if he knew you, and he said he'd heard of you. Well, I said, I had lunch with him 3 weeks ago. And the doctor said to Jay, no, Jay, he's so old, he's dead. You probably had dinner or lunch with his son. And so it established my age. So I need to let you know that I was born before jet travel and superhighways and television, but I wasn't born before arthroscopy. Interestingly enough, the first arthroscopic meniscectomy was reported in the Illinois Medical Journal in 1927. In my orthopedic residency, they did only open shoulder surgery, Putty Platt, Nicola, I don't know if you heard of those, and Magnuson Stack. And I never saw an arthroscopy, let alone an arthroscope. In my practice years, the Bristol was popular. And so we moved forward into arthroscopy, and you can see the large television supported on the ceiling with an articular viewing scope to be able to look. And the most common views seen in the early days of arthroscopy were a red out and a white out. Red from bleeding and white from being lost in the fat pad. But then things got better, and we had miniature cameras that gave better views, and along came motorized instrumentation that made things a lot more efficient. And we also got better understanding because of arthroscopy of the shoulder. Originally, it was thought that all the glenohumeral ligaments are same size and also were horizontal in orientation. We learned they weren't the same size, and they were oblique in orientation. And the wonderful thing about arthroscopy was the opportunity for second looks. Here shows that a blood clot forms just like it does on your skin, and subsequently there's a fibrous healing of the tissues inside the joint the same way it would be outside the joint. And interestingly enough, and ironically, the people most against arthroscopy of that day were the sports medicine doctors of that day. Of course, we know the end of that story. And then we have my dear friend Charlie Rockwood, who came out with the tool of the devil, arthroscopy. And I have to tell you that Charlie and I were very close friends. He spent time with me. I have videotapes of him performing arthroscopic surgery on my patients, and I can tell you that he was really good. Why he never went forward with it or advanced it, I don't know. He could have done it really easily. I have the documentation to show that. So we've come a long way from metal stapling, I think the first arthroscopic reconstruction in 1982, and now we have suture techniques that are much, much better. But what I want to talk to you about today really are three challenges I've been thinking about. One is innovation is lacking. Treatment of infections has really bothered me, and we need to retain some responsibility with authority. Responsibility we've been given, no authority. I hope I'm going to motivate somebody today. So let's talk with the lack of innovation. This amazed me. Chris Harner, a friend of mine, now is with the FDA. And except for the spine, no new orthopedic FDA applications in 10 years. Amazing. No pre-market applications. Only 510K. It looks something like what already exists. Well, why is that? It's pretty obvious that a pre-market application can take maybe $1 billion in 8.5 years. One took 24 years. And a 510K can take maybe an average of 2.5 years. So you can see why that makes sense that we're not seeing them. Now, here's another important point. Invention's not innovation. There can be thousands of ideas. For every 100 patent applications, 41 are granted an invention. How many make money? 1%. Now we understand the market decides if the idea moves from invention to innovation. Now, here's some fundamental reasons. You might have an idea, but here's the problems. One, we have too much groupthink, which I understand sociologically is important. Echo chamber environment, risk aversion, and here's one that's really come to me. Why would you have a single observation and not motivate you? So I've come to say this: a series of one is better than a series of none. And so you can have an idea, don't let it just drop there, go for it. And I'm saying, get out of the box if you want to have some innovation. Now, I have to tell you what's about the future. I'm a relic of the past. Going it alone, I don't believe will happen anymore. Future must include government or established company, a big industry. I just don't think it can happen by a person anymore. Here's my second concern: infection and orthopedic surgery. No ready solutions, and no one really cares. If a person gets a total joint infection, of course you have 100% morbidity. But no one seems to realize, although published regularly, the mortality at 5 years is 25%, greater than breast cancer or prostate cancer. But no company's interested. Now, I'd like to ask you this. How many of you know and can raise your hand you're familiar with the concept of Persister Bacteria? Over here, anybody? Oh, one. In here, anybody else? Well, I'm happy I'm here today. Here's some important pathological things about infection, and I've been working on. One, of course, is there's the antibiotic resistance of the biofilms. But I need to draw your attention to Persister Bacteria, because when you have bacteria on your skin or somewhere, what happens is that a group of them become metabolically inactive or form a biofilm. And every 20 minutes, they recolonize. Might help to explain why we have some infections. So let's think of Persister Bacteria this way. If you get a strep throat, you don't get one pill and one shot. You get a shot, and then you come back and get another one, 7 to 10 days, and you continue. But why? Because the recolonization of these persisters go on until you further can decrease the bacterial load, or you no longer have a pathological condition that your immune system can't handle. So I want to hammer on Persister Bacteria and tell you something you might do. They remain after skin disinfectants, because our skin disinfectants are only temporary, and the antibiotics are only temporary. I told you about the metabolic inactivity and the biofilms formation, and in your mind, I want you to know 20 minutes of recolonizing while you're doing the surgery. So plastic draping can be a help, but I think changing out the instrumentation, which are a culture media sitting over on the table for half an hour is an important way. I would probably, if I was still a doctor, I would probably change them out. And then repetition of wound wash, because we know that the wound wash will decrease the amount or the bacterial load, and of course we use postoperative antibiotics. I've been doing some research because of my concern, come up with a reagent called protocochoic acid, and it has some therapeutic benefits against antibiotics, and one is the crystal is not like salt or zinc, it's like this. It's a crystal that has sharp prongs on it, and which will then focus on the target bacteria, virus, physical disruption, and a biochemical deployment. Second of all, it adheres to skin or tissue or to implants. So it offers a great opportunity because strong physicalization and because it has slow insolubility. Now I want to give you a tip about acne of the shoulder because I got interested in that. I saw it was a problem in shoulder surgery. And so acne resides deep in the sebaceous glands, deep the surface, or in the hair follicle. And the chemicals we use on the surface are generally non-penetrating, even though the bacteria is below. And we don't know that they're acne specific. So the solution, I think, even today that can be done would be one I would do pre-cultures on all my shoulder patients. Earlier today, when they showed the instabilities of the shoulder, a number of those patients had acne all over their shoulder. So my question, if I was on the panel, they said, what operation? I'd say absolutely none, no matter the condition, because acne exists there. But when we did a group of medical students, which we reported on the Bone and Joint Journal, that only 2 of the 20-some had positive cultures for acne. And it was floored, too many to count. And so what I would recommend if I was in practice now, I would culture all my patients that were going to have shoulder surgery ahead of time. If they were going to have acne, then what I would do is I would either treat them topically and or defer surgery until they were negative. So I think that's a take-home message you can take that could be implemented now and perhaps reduce that risk. Now, invention, of course, is not innovation. There's a high barrier to getting things through, and I'll tell you what, basically you got to have a commercial partner, but none of them are interested in infection. I could give you another hour talk on my experience. No return on investment. No new antibiotic class in 35 years. Why? No money. Here's the one that really bothers me perhaps more than any. One is that the physicians are having responsibility, no authority, and you're reduced to actually a labor category, the best I can see, and there's no say in management. If I was there, I would really be troubled. Now, the buyers of your license happen to be the hospital administration, insurance industry, government, venture capitalists. And who earns more, management or labor? Who has more to say, management or labor? So who has become the losers in this situation? Now, I want to tell you about an alternative that actually is a franchise and has an opportunity to get your attention no matter what practice environment you're in. And you'll have to come to a little careful understanding of this legally because of the history of different things. But you can create value for your hospital and be rewarded for it. You can take more responsibility in exchange for more authority and more income. And here, carefully through the steps of this franchise, is one, you have to have an enterprising doctor who has a good relationship with the hospital. The doctor introduces the concept of the hospital, which is about to follow. And the main thing for the hospital is you can greatly reduce the hospital's spend. So if it's accepted, then what comes in is the company that's a franchisee comes in and said, we'll perform a cost analysis, we'll show you real cost reductions, we'll show you have a long-term contract, and show you how you're going to save money with no compromise. So the doctor, as a role as a franchisee, is advisor to the hospital. The franchisor provides a list of product sources. The hospital and doctor make independent decisions on products, no compromise. And the doctor, as a franchisee, receives fixed percentage of the franchisor's income. This has to be this chapter and verse to avoid any legal problems. So the consultation contract is fixed with the hospital, supplies a list of cost-effective quality products, not selling any product, no kickback from any product, no payments related to cost savings or percentages. So the doctor as a franchisee, most franchisees you have to put up money, this you put up no money. In this situation, because if you can make that arrangement with the hospital, you get paid a fixed percentage of the hospital's contract. So is quality compromised? No. The doctor is in the decision making and he's in control. Where's the profit? The profit's in the margin, the difference between products and their cost. What do products cost? Well, take suture anchors, Steinman pins, screws, total joints. But for example, real savings in the spend. On just pins, one hospital saved $500,000 a year, of which, as a franchisee, if you work that out, it's fixed, you have a say what pen you're using, no compromise. You're going to get a better price, and you also will have some say and some income. So what happens? The company representative, of course, is gone. You do know that they often earn more on a per case than you as a surgeon, but they're paid from the sale of the implant cost. So we have to shift the cost and responsibility. Who does it go to? The hospital employee then takes over increased responsibility, increased pay, increased satisfaction, and he's directly responsible to the doctor. So where are we now? I have concerns about the innovation. You got to have an idea. There's certainly challenges and opportunities. You got to join with the company or the government. Orthopedic infections have to be addressed, and I'll just tell you as a sidebar, I'm addressing it. But they're new issues. I think if you do preoperative cultures and you're aware of Persister Bacteria, repeated irrigations, you can reduce the chance. And we've got to have a new type of alignment that gets the doctor in charge. Perhaps a franchise model is it. And I want to thank Jim Esch for his 39 years of hard work to make such a fabulous product. Thank you, Jim.
So what I had, Lanny, with this concept is my partners like their sales rep, and they don't want to hurt the sales rep, so they want to have anything to do with this. So it's just an observation.
Allegiance is a wonderful thing, and then we got to decide, are we in charge, and do I have authority with my responsibility? And
Correct.
I understand what you're pointing out, and that is a hindrance to moving ahead.
So one other what are your thoughts on, I'm tired of dealing with my 13 partners and all that, so I'm going to join the hospital because they're going to give me a bunch of money to work for them, and it's going to be wonderful, and I don't have to deal with all these people again. So what do you think of that?
Well, I'm almost 89 years of age, and I quit practice at age 62, and the main reason was I could not stand the office meetings with young doctors. So I understand that part. The second part is that you've just become an employee, and so you have different responsibilities. What I was addressing as practicing orthopedic surgeons and how much they had to say in their life.
Yeah. Okay. Thank you. Any other questions? Okay, so Lanny, thanks for your ideas, and your brain's still moving along.